Hi, this is Dr. Jonathan Hall coming to you from Boston with another episode in A Thoughtful Patient's Guide to Plastic Surgery. Today I'm going to talk about the inverted or retracted nipple. This is often a problem both functionally and aesthetically. Women tell me that it can be difficult to keep the nipples clean and they don't like the appearance of a retracted nipple. So this is an article that was published by two Korean plastic surgeons from Seoul, Korea in August of 1999 and grades the severity of nipple retraction based on how easy it is to pull the nipples out. So they put it in categories 1, 2, and 3, and it's named after the authors Han and Hong. So grade 1, the nipple is easily pulled out, maintains its position easily, has little or no fibrosis and no soft tissue deficiency. Grade 2, the nipple can be pulled out, but not as easily. It has difficult holding its position, kind of tends to pull back in. There's moderate fibrosis and mild retraction. Grade 3, it's difficult to pull out, often needing a traction suture, and it promptly retracts. The milk ducts are short and severely retracted. So people have talked about barbell piercings to stretch the ducts, leave them in for a while. Most of my patients don't find that acceptable. Most methods of correction involve some way to cut the shortened ducts and then some way to keep them from reattaching, often with flaps or grafts placed between the ducts. So whenever there are multiple methods of correcting a problem, it usually means that most of them haven't worked out completely satisfactorily. I'm going to show you the method that I finally settled on after 15 years in practice and I've used now for the last 20 years, and it's been the best in my hands for correction of the retracted nipple. It's a modification of a micro-incision technique. So this article was published by some Brazilian plastic surgeons in 2001. They used a special device called a no-core needle. Like it sounds, it's a needle that doesn't have a core, and it's really just a small blade on the end of a needle shape that allows us to go in with just 2 puncture wounds and release the ducts with the little blade. So this is a picture showing the microincision technique of the authors. They go in and release the ducts, but now they then describe using that traction suture and taping it up for 4 days and down for 4 days, having the patient move it back and forth. That's a little more than my patients want to get involved with. And what I've found is this splint that was described by a British plastic surgeon in 2003, where we cut the barrel of a sterile syringe and then get the rubber stopper from a little larger syringe as a cap. Then a traction suture is placed through that top and used to hold the nipple up to length. Now, while it's held up to length, it fills in with soft tissue behind the cut ends and keeps it from retracting. I then have patients wear eye pads for about 6 weeks. So while the nipple stent is in place, gauze pads can be fluffed up and arranged like a bird's nest around the nipple so it can be hidden under a bra. So a good demonstration of this is a case of one of my patients with very severe nipple retraction, probably the most severe that I've seen, that had not responded to previous treatment. So here's a scientist in her early 30s who had recently moved to Boston from Europe. She'd had an attempt at surgical correction of her nipple retraction 3 years before in Europe, and they'd used dermal flaps where they cut across the areola and made flaps to place in between the cut ends to try to keep it from retracting. Unfortunately, she had a partial recurrence on her right and complete recurrence on her left, and was still grade 3 on both sides. When I asked her, she did not have any type of stent or bolster after her first procedure and was not asked to wear protective gauze pads. She loved the shape and size of her breast, but remained unhappy about the retraction of her nipples and asked if I could improve it. I thought this was going to be a real test because her nipples were really scarred in. But here we are at 6 weeks, and we got a very successful correction. So her right side's not as severe. The 3 arrows show the scar across the areola from the dermal flaps on the right side, and the correction that I was able to achieve is shown after 6 weeks. No new scars. We were able to use the microincision technique, so just the 2 puncture wounds, which don't really leave a scar. And here's a side view, before and after correction, and here's a more close-up view of her right side before and after correction. Again, that was not as severe, but still I would consider it Han and Hong grade 3, very difficult to pull the nipple out. Here's her left side, even more severe. The arrows show the scarring from the dermal flaps, and a scar across the areola. Again, I did not need to make a new scar. I was able to release this with a microincision technique. The whitish scar that you see on the left was the same scar from her first procedure that now is revealed more because it's not hidden in that crease. But here's her side view showing a nice correction before and 6 weeks after. And here's a close-up view. Again, not perfect, but dramatically better, and she's satisfied with the correction we got in a very difficult case. I think this is a real test of the microincision technique. Here's another patient of mine in her early 40s, before and 9 years after. She was bothered by deflation of the breast as well as nipple retraction and had a breast augmentation with smooth, round silicone gel implants placed partial subpectoral, that's below the muscle, through an inframammary incision. She remains thrilled with the beautiful natural look of her breasts after surgery and has kept her correction with the microincision technique. Again, before and 9 years after surgery, and a side view before and 9 years after surgery. So here's a young woman in her late teens who's bothered by severely retracted nipples. She would be considered Hannon grade 3, the most severe retraction. The nipple is very difficult to pull out and properly retracts. So again, a front view before and after, a nice correction, a side view before and after. Here's an 8-year follow-up on a patient of mine who had correction of a retracted nipple on her left side. She's bothered by this retraction for more than 25 years. She was able to manipulate this enough to bring it out to breastfeed her children, but was bothered still by its appearance. She'd be a Hannon grade 2. She could pull it out with manual traction, but it would promptly pull back in. So again, microincision technique and release, and really a nice result for her before and showing 8 years after. And a close-up view from the front and from the side before and 8 years after. Here's a mother of one in her later 20s who's bothered by a retracted nipple. Her right side was moderate and her left side was severe, so Hannon grade 2 on the right and grade 3 on the left. She's shown before and again after, 6 weeks after retraction. And here's a side view before and 6 weeks after correction with a nice projection. Here's a mother of 2 in her early 50s who's bothered by a deflated appearance of her breasts after pregnancy. She also is bothered by inverted nipples. She wanted a full but still natural look and selected a 375 cc size. She shows before and again 6 weeks after bilateral partial subpectoral breast augmentation with a dual plane placement of 375 cc high profile textured gel implants placed through the inframammary incision. High profile was chosen to restore some of her lost upper pole fullness. The pros and cons of using a textured implant were discussed, and we chose a textured implant with the least aggressive texture to decrease the potential lateral shifting of her implants with time. Keller funnel was used to place her implants along with antibiotic irrigation and nipple shields to decrease the risk of biofilm contamination. And then following the procedure, at the end of the procedure, while she had IV antibiotics on board, a microincision technique was performed to release the retracted nipples. So here she is before and 8 weeks after her surgery. We'll expect that her breast will soften and look even more natural with time. Here's a side view before and 8 weeks after surgery. Here's a mother in her later 50s, always bothered by retracted nipples. She would be a grade 3, and here she is before, and here she is on the right picture after, 6 weeks after surgery. And here's a close-up view before and 6 weeks after surgery. And here's a side view before and 6 weeks after surgery. Here's a mother of 2 in her later 30s, bothered by a deflated appearance of her breasts after pregnancy as well as by inverted nipples. So she's shown before and again 8 months after bilateral breast augmentation with the microincision technique used at the end of the procedure for release of the nipple. She has a tattoo which I've blurred for her privacy, but the pictures are otherwise unretouched. Here's a single oblique before and after of another patient of mine with breast augmentation and correction of retracted nipples at the time of surgery. I could not find her other slide, so I apologize for that, but a nice result here. Here's another patient of mine, a mother of two in her early 50s, who was troubled by the retracted nipples since she developed breasts. She complained of crusting and irritation in the nipples, and here she is 6 weeks after surgery, excellent projection appearance, and no more crusting and irritation in the nipples. Here's a close-up view before and 6 weeks after surgery. And here's a side view before and 6 weeks after surgery. Here's a professional woman in her mid-50s with a more than 25-year history of a retracted nipple on her left side. The arrow shows the left side. She could manually pull this out enough to breastfeed her children, but it always bothered her. So she'd be a hand-and-haw grade 2. She could pull the nipple out, but it would promptly retract. So she's shown here before and 7 weeks after the microincision technique under local anesthesia in the office. Here's a close-up from the front and again from the side. So today we've learned about the anatomy and grading of the inverted or retracted nipples. I've shown the technique that's worked the best in my hands over the past 20 years, a modified microincision technique with release of the tethered nipple ducts with the microincisions combined with a syringe barrel stent for 7 to 10 days and protective iPads worn for 6 weeks. So thanks for listening. This is Dr. Jonathan D. Hall coming to you from Boston. I hope this has been helpful.